The purpose of the pulmonary examination is to evaluate the function of the lung and to investigate for pulmonary disease. Pulmonary function can be evaluated by looking at oxygenation and by looking at respiratory mechanics of the thorax. The examination on this tape is not necessarily the way it must be done, but is one method. It is important for every student to develop a system and be consistent in performing that examination. The lung is a symmetrical organ, and it is important to compare one side to the other. The examination consists of 4 steps: inspection, palpation, which in the pulmonary examination is primarily measuring chest wall expansion, percussion, which is used primarily for measuring diaphragmatic excursion and pleural effusion, and auscultation. We encourage students to tell patients what they are doing as they progress along the steps of the examination. This will not only reassure the patients, but for the students reinforce the sequence of the examination. Initially, one needs to observe how the surface anatomy relates to the underlying structures. The lungs extend higher than expected and actually extend above the clavicles. Anteriorly, the heart obstructs much of auscultation, but one hears the upper lobe, part of the middle lobe, and a little of the lower lobes. Laterally, one has access to the right middle lobe and left lingula. Posteriorly, only the upper and lower lobes are represented. Unless one listens over all 3 areas, one will miss findings, particularly ones that relate to the middle and the lingular lobes. To describe the position of chest findings, one uses horizontal and vertical coordinates. The horizontal coordinates are the ribs and the intercostal spaces. To locate the ribs, one needs first to find the angle of Louis, or the sternal angle, at which point the second rib meets the sternum. The sternal angle is formed by the junction of the manubrium and the sternum. Just below the second rib is the second intercostal space. Other landmarks are identified by marching down the chest wall, feeling the third rib, third intercostal space, fourth rib, fourth intercostal space, and so forth. The vertical landmarks are the mid-sternal line, the mid-clavicular line, the anterior axillary line, laterally the mid-axillary line, and posteriorly the mid-vertebral line and the mid-scapular line. After understanding the surface anatomy and its relationship to underlying structures, the examination begins by inspection. First, look at oxygenation, and second, look at the function of the thorax as a respiratory organ. One can get an idea of oxygenation by looking at the color of the nail beds, lips, and skin. In this patient, the nail beds are pink, and the lips are of normal color. Poor oxygenation results in a bluish, dusky cyanosis. Notice in this other patient the dusky or cyanotic appearance. The next observation is to look at the breathing pattern. Notice rate and character of respiration. In the normal patient, breathing is almost imperceptible. There's little movement of the chest wall except for slight movement of the rib cage. Notice that the sternum is almost completely still. In many pulmonary diseases, there is hyperinflation, or an increase in intrathoracic volume, which necessitates abnormal movement of the thorax. In some diseases, the rib cage at rest is in an expanded diameter. Therefore, intrathoracic volume must be increased by movement of the sternum, using the interthoracic muscles. There is increased movement of the sternum in an outward vector and decreased movement of the lateral rib margins. Notice also that the patient is breathing more rapidly. All these changes indicating disease are readily available simply by inspection. In this patient, notice also the rapidity of breathing and the movement of the sternum. She has difficulty in talking because of her respiratory compromise. This can be a clinical indication of disease. The next step in the examination is palpation. One can use the exposed thorax to get a general sense of texture of the skin or to identify skin lesions. However, in general, in the pulmonary examination, palpation is limited to measuring chest excursion. This can be done either anteriorly or posteriorly and demonstrates the normal symmetrical expansion of the chest wall. Place the thumbs against the vertebrae and the fingers around the lateral chest wall and allow the hands to move with chest expansion. In a patient who has had recent trauma to one side of the chest or may have pain from infection, there may be splinting of one side, as seen in this case. Notice only the one side is moving. In this patient, there is diminished lateral expansion because of hyperinflation. Most of the movement is in the sternum. There's little lateral expansion. The percussion is used in the pulmonary examination and in other examinations. Percussion is done by placing the hand on the object to be percussed. Lift all the fingers but the one to be struck in order not to tamp the vibrations. Percussion, by the other hand, is done by movement at the wrist and not by the elbow. One of the most common mistakes is to move only the elbow. Instead, percuss firmly, but not hard, from the wrist. Hold the finger curved but fixed. Some examiners find it useful to support the percussing finger with an adjoining finger. Percussion is done by striking the ball of the finger onto the knuckle of the percussed finger. This is a technique that must be practiced over and over. Notice the different notes. Dull over a solid surface, in this case the liver. Resonant over a hollow viscous, in this case as he approaches the stomach. To percuss diaphragmatic movement, have the patient take a deep breath and hold it. Percuss the level of the diaphragm. Then have the patient let the air all the way out. Hold it and percuss the level of the diaphragm at maximum expiration. This will give you 3 to 5 centimeters of diaphragmatic excursion, which is normal. I think it is useful to mention that you must be conscious of what you are asking the patient to do. In the excitement of finding possible abnormalities, you must forget that you have told the patient to hold his breath, to the discomfort of the patient. You might practice holding your own breath whenever you ask patients to hold theirs. You will be able to gauge their discomfort by your own. Auscultation is done with a stethoscope, which is composed of earpieces, tubes, and a head that is used to pick up vibrations. Place the earpieces in the ear canal, ideally making a seal. The head is composed of a diaphragm for picking up high frequencies and a bell for low frequencies. The head may be rotated to the desired diaphragm or bell. Tap the head to make sure the head is in the correct position. Before putting the head onto the patient, rub the metal, which may be cold. Auscultation is done with the diaphragm of the stethoscope, which picks up most pulmonary sounds better than the bell. Auscultation is done in front, lateral, and back, using a side-to-side pattern. Have the patient take breaths with the mouth open, which accentuates breath sounds. It is important to listen carefully to both sides over all lobes and compare them. The auscultatory noises are created by air moving through the large bronchioles. Therefore, the sounds anteriorly will be different from the sounds posteriorly because the high-pitched frequencies are absorbed by lung tissue as the vibrations move through the chest. Anteriorly, the sound is harsher and higher pitched and is heard throughout inspiration and expiration. Posteriorly, the sound is less harsh, lower pitched, and disappears about midway through expiration. Normally, one should hear no other sounds but the vibrations created by movement of air through the large tubes. However, disease states may cause abnormal sounds with which you should be familiar. Abnormal sounds are generally divided into two categories: continuous sounds, known as wheezes and rhonchi, and discontinuous sounds, known as rowels or crackles. Wheezes or rhonchi can be high-pitched or low-pitched depending upon the frequency of the vibration. Rowels are discontinuous sounds caused by the popping open of small bronchioles. The literature frequently mentions moist rowels, dry crackles. However, I think it is best only to recognize the general category of rowels. Many authors feel that rowels cannot be separated.